This is Anesthesia Circuit with John Kenny, the only show dedicated to all things anesthesia.
Hello, that's right. This is Anesthesia Circuit with John Kenny, the only show dedicated to all things anesthesia. I'm John Kenny. Now, this is the first episode on this channel, and I'm really excited to bring you this content. Now, what I've done here is I brought together this podcast basically with the intent to cater to the busy clinician. Now, as clinicians, we're very busy. We don't have time always to keep up to speed on everything going on within our field. And so what this podcast will do is it'll give us that opportunity to kind of stay abreast of all those things, all these topics, and keep us up to speed on everything in the world of anesthesia. Now, each of these episodes are going to be divided into segments designed to give you a quick overview on what's going on in this anesthesia world. It will also present anesthesia keywords to help keep our clinical minds sharp. Now, these segments are going to include personal health. Now, this is going to give us data, tips, opinions on what we can do in order to keep ourselves in tip-top shape so that we have a good balance in our lives, so that we can give our full selves to our patients. Another segment will be keywords. Now, this will be geared more towards our residents and fellows who are taking the exams and things like that. Now, these are common topics that are going to be tested on the exam. And I'm going to go through the keyword to give us a review of that, so it'll keep our minds sharp on the day-to-day. I'll also present a segment on current research. That's where I'm going to scour some of the anesthesia literature and cherry pick some of the really more important articles or studies that have been presented, that have been published, that are going to be really interesting for us going forward. Another segment will be anesthesia news. Now, this is going to be more of the mainstream kind of news that may affect us. This may be public policy. This may be, big, news breaks that have come out that affect us in the anesthesia world. And then finally, I'll have announcements every episode as well. These are going to be things like upcoming conferences, any deadlines, application deadlines for residents and fellows and things like that. So everything really concise to keep you, up to speed on everything. Now, when I created this podcast, I had the busy trainee in mind. What I wanted to do was present something that the trainee would be able to listen to while they were in their car, while they were working out, so that they can keep, up to speed on everything in the anesthesia world. That being said, this podcast is definitely useful for anyone in the anesthesia world. It's going to give you information. Not only it's going to keep you sharp and up to speed on everything that's going on in the world, but also give you something to talk about when you're in the anesthesia workroom, hanging out with your colleagues. And with that, we're going to move on to the first segment. Personal health segment. All right, let's get right into this. This segment is deliberately placed first because our personal health is of the utmost importance in order to practice effectively and give our best to our patients. Now, although this isn't specific to anesthesia, it's paramount to being on top of your anesthesia game. Now, personal health is recognized as being so important that the AMA has adopted a policy to combat depression, burnout, suicide, in healthcare practitioners with the emphasis on residents and fellows. Now, as the former AMA president Robert Waugh put it, the most important patient we have to take care of is the one in the mirror. Let that sink in. I think I couldn't have put it better. Now, it's well documented that there are increased rates in suicide, depression, and burnout, and decreased personal and professional satisfaction among physicians. This has been attributed partly to increased administrative workload, while there's a decrease in the actual face-to-face interaction with patients. Now, this has inspired the AMA to create a module with the aim of helping residency and fellowship programs to create a culture of wellness and mental resiliency among trainees and clinical educators. Now, this module was created in part by Toyin Okalawan, who's the Senior Healthcare Research Associate at Harvard Business School. Now, the module is named Physician Wellness, Preventing Resident and Fellow Burnout. And the module can be accessed through the AMA website. And I will include a link at the end as well, so you can get to that. Now, this module gives excellent information on the current state of the problem and instructs us on how to implement an effective or an effective program at your own institution. Now, in future episodes, I'm going to break down components of this module. I'll also present topics on diet, exercise, meditation, and volunteerism. Now, that last one's a really important one, I think, and it doesn't get as much play as it should. Volunteerism is a great way to get out of yourself, and the effects have been shown to decrease our stress and give us an overall just feeling of well-being when we do that. And it doesn't have to be something crazy. You can do a half hour, a week or so, just getting out of yourself and giving back to the community. I'll also present other published research in order to give you the tools to live healthier lives and more balanced lives. Anesthesia keywords. All right, here we go. This is the basic keyword today. Once again, I'm going to give you one basic and one advanced keyword in every episode. I'm also going to compile all of the keywords into one file or one podcast so that you can just pop that on when in the last couple of weeks right before the exam, and it will give you a really high yield study tool to help with your studying. All right, so this first word is from the basic section. It is ACE inhibitors, mechanism of action. Now, each of these keywords are things that have been tested in the past. They've been shown that there's a decent amount of people who miss these, and so these are going to be these high yield things to keep in mind. All right, ACE inhibitor. So we know that ACE inhibitor stands for angiotensin converting enzyme inhibitor. And what it does is it disrupts the renin-angiotensin-aldosterone, the RAS system, by preventing conversion of angiotensin 1 to angiotensin 2 by blocking the angiotensin converting enzyme. Now, angiotensin 2 is a potent vasoconstrictor. And so when you have this relative decrease in angiotensin 2 when being administered an ACE inhibitor, you have peripheral vasodilation, but then you also have vasoconstriction of the afferent and efferent arterioles in the renal microvasculature. There's a preferential increase in the efferent resistance, which actually increases your renal perfusion, or actually your GFR, which allows you to excrete water. Now, a little about the RAS system. Now, it's activated when there's decrease in renal blood flow detected in the kidney. So either hypovolemia, heart, liver failure are a couple of the things that cause that. Now, the end products of the RAS activation are angiotensin 2 and aldosterone. Aldosterone is a mineralocorticoid that causes the distal tubules and collecting ducts of the kidneys to resorb more sodium at the expense of potassium. The sodium in, potassium out, okay? And that's aldosterone in the native system. Now, this increase in vasoconstriction and sodium resorption results in high blood pressure and retention of volume. Now, there's a negative feedback loop that inhibits the RAS system once the kidney perfusion has been restored. Now, this loop may be impaired in certain pathologic states, like essential hypertension. ACE inhibitor class of antihypertensives are especially helpful in comorbid conditions like acute myocardial infarction, systolic heart failure, chronic kidney disease, and then preventing the progression of diabetic nephropathy and retinopathy. Now, of note, here's another thing that sometimes I've seen tested. Bradykinin is inactivated by angiotensin converting enzyme. Now, this is why some people will develop a cough when they're taking an ACE inhibitor, because the bradykinin isn't converted. And so just kind of remember that, bradykinin, ACE inhibitor, and cough. All right, next is the advanced topic. This one is abdominal compartment syndrome diagnosis, okay? So the definition of abdominal compartment syndrome, or ACS in this case, is organ dysfunction caused by intra-abdominal hypertension that leads to impaired perfusion. Okay, so you have organ dysfunction and increased intra-abdominal hypertension. So it's a syndrome here. Now, the characteristics are going to be an increase in intra-abdominal pressure, obviously, increased peak inspiratory pressure, decreased urinary output in spite of adequate cardiac output, and then the 3 H's. That's going to be hypoxia, hypercapnia, and hypotension. The first two have to do with the increased intra-abdominal pressure causing inability for ventilation or for lung excursion into the abdomen. Now, the causes can be a few, and I'll just name a couple here: sepsis, abdominal trauma or surgery, large fluid resuscitations with third spacing into the abdomen. All right. Now, diagnosis. So we always start the diagnosis with a physical exam at the bedside. You always go to the bedside, lay eyes on the patient in order to get your best assessment. The abdomen can be tight and distended. There can be decreased peripheral pulses. There can be decreased urine output. Now, this is going to be confirmed by measuring the bladder pressure. So this is surrogate for measuring the intra-abdominal pressure, or IAP. In end-stage acute or abdominal compartment syndrome, it's defined as end-stage organ damage and an intra-abdominal pressure equal to or greater than 20 millimeters of mercury. Okay, so you have both of those things. Now, when the IAP gets into the range of 25 to 35 millimeters of mercury, which is a grade 3, this will ultimately require decompression. Now, if it's just in that stage 20 and above, you can actually take other, you can employ other treatment strategies. Potentially, if the patient's ventilated, you can paralyze them to help reduce that while you're also treating the cause of this increased pressure in the abdomen. But what the authors are saying is that between 25 and 35, most likely they're going to require a surgical decompression, and then all patients with an intra-abdominal pressure greater than 35 millimeters of mercury will require immediate decompression, because this group of patients probably won't respond to your more conservative measures, and also these patients can deteriorate into cardiac arrest as well at any time. So the treatment is going to be rapid decompression of the pressure by opening the abdominal wound if they're post-surgery, or opening the abdominal wall, and then closing it with a temporary wall, mesh, or plastic bag. Physiologic consequences that we see with persistent elevated intra-abdominal pressure. So these are also things that can be tested. So you're going to have decreases. So here are your decreases. Decreases in cardiac output, decrease in central venous return, decrease in visceral blood flow, decrease in renal blood flow, so visceral renal blood flow as well. Now, the increases, you're going to have increase in heart rate, pulmonary capillary wedge pressure, peak inspiratory pressure, central venous pressure, and systemic vascular resistance. Now for the current research segment. During this segment, I'm going to present an article or articles that I've picked out of the current anesthesia literature that I think are going to be important to us as anesthesia providers. Now, today's feature article comes to us from the July 2018 issue of Anesthesia and Analgesia. Now, it's a narrative review article from Pivalitsa et al. Out of the University of Texas Health McGovern Medical School in Houston, Texas. Now, this article is entitled Whole Blood for Resuscitation in Adult Civilian Trauma in 2017, a Narrative Review. Now, the purpose of this article was to reintroduce us to the idea of whole blood transfusion in the setting of acute clinical trauma and massive transfusion. This narrative discusses the current data on whole blood transfusion and the experience of implementing a whole blood transfusion strategy or program at this level 1 trauma center. Now, if you work in an institution where you're employing massive transfusions, trauma centers, you're going to want to pay attention to this, because this may very well change the way that we transfuse in the near future. Now, since the inception of blood banking in World War I through the Vietnam War, whole blood transfusion has been the way to go in the massive resuscitation scenarios. Now, in the as component separation and storage became more advanced regarding blood products, transfusion of individual blood components gained favor. And actually, there were a bunch of studies, landmark studies in the 1980s, that argued superiority of component treatment over whole blood in a hemorrhage scenario. Since then, through military and civilian trauma data, it's established that the 1-to-1-to-1 plasma to platelets to RBCs transfusion ratio was the best. Now, in the early 2000s, in the front lines in Iraq and Afghanistan, there was a lack of refrigeration and a paucity of platelets, and this required the military to employ warm whole blood and platelet transfusion in trauma scenarios. Now, the evidence from this military medical data suggests that type-specific whole blood is a safe alternative to the one-to-one-to-one strategy employed in civilian hospitals. So out of necessity, the military was able to compile this data that actually shows that, hey, maybe we had it somewhat right back in the early to mid-19th century. Now, additionally, in 2013 in the Annals of Surgery, Cotton et al. Published a prospective randomized control trial of modified whole blood plus platelet transfusion. And what it did, it appeared to provide hemostatic resuscitation with less overall blood component volumes in the sub-analysis. So the whole blood, actually, they were transfusing less when they transfused whole blood versus the component therapy. So if you're inspired by this article and you want to employ a whole blood transfusion program at your own institution, now the authors have featured in this study, they've outlined strategies necessary for success. So they kind of give their experience, and these include comments on what they had to do from the regulatory standpoint, the blood supplier standpoint, education of practitioners, safety for patients, and then early process improvement, what they had to do when they were going back to improve things. Now, the author suggests that with increased utilization and evidence, the national regulatory support is only going to follow, and whole blood transfusion programs actually will gain favor pretty soon. That's what these authors have been saying. So it's something to look into for sure. All right, on to news. So in drug shortage news, yeah, that's something that we all deal with on a daily basis. Well, this is good news for us. So on July 12th, 2018, Scott Gottlieb, who's the commissioner of the Food and Drug Administration, released a statement regarding the information of a new drug shortages task force. All right, so people dedicated to keeping abreast of this. Now, and the FDA's effort to search for long-term solutions on the drug shortage problem. That's just great for us. Now, while citing improvements, he also said more can and must be done across our healthcare system to achieve more enduring solutions to the problem. According to the ASA website, this announcement follows transmission of an ASA co-led bipartisan letter sent to the commissioner last month. Over 130 lawmakers from both chambers of Congress sent formal congressional letters urging the FDA to address critical shortages of injectable anesthetics and intravenous pain medications. Now, in other news, the ASA president-elect and pediatric anesthesiologist Linda Mason gave a recent interview regarding the safety of anesthesia in children. Now, she's quoted as saying, "Parents should rest assured that surgery is only recommended when necessary, and your child will be monitored during every minute of the procedure to ensure the safest and most effective care." Her statement helps to clarify a 2016 FDA warning about the effects of repeated or lengthy use of general anesthesia on the development of children's brains. Now, this warning was based primarily on the results of studies from laboratory animals and may not be translated to humans. Dr. Mason went on to say that in an effort to continually improve anesthesia, physician anesthesiologists have been at the forefront of research on the effects of anesthesia on children and adults and continue to study this important issue. There have been hundreds of studies published over the last 50 years investigating anesthesia's effects on the developing brain and no conclusive findings on whether the use of anesthesia poses a risk. Okay. Now, this is not said to dismiss a parent's concern. Now, I'm going to be a parent coming up very shortly. I know that all that a parent wants is to ensure that their child is safe. They're the protectors of their child. And so what the official ASA, the ASA has put out official guidelines for parents. And what they say is, one, don't delay or avoid surgery, but instead talk to the physician anesthesiologist. And then also rest assured that limited exposure to anesthesia is considered safe. Now, the ASA has even provided a resource for preparing your child for surgery and questions to ask the anesthesiologist about when you're preparing for surgery. That information is at asahq.org/kids checklist, all one word, KIDSCHECKLIST. Now, additionally, there's a ASA companion coloring book for the kids who are about to undergo anesthesia and surgery, and that can kind of help them if there's any fears. And that can be accessed from that site as well. All right, as for announcements, the American Society of Anesthesiologists main meeting, Anesthesia 2018, will be held in the City by the Bay, San Francisco, California, October 13th through the 17th. This year's conference bridges research and technology with patient care while facilitating face-to-face collaboration with more than 14,000 peers through leaders and anesthesia providers from more than 80 countries are going to be here. Now, Anesthesiology 2018 will take place in the Moscone Center in San Francisco. The Moscone Center is nearing completion of a $551 million expansion that will offer brand new flexible space and many more amenities. Attendees will experience a portion of the expanded building. Ooh, exciting. Sign up today as the early bird registration ends July 24th. So that's where you can get a little bit of money off when you're signing up. Now, aspiring pediatric anesthesiologists and pain medicine physicians, keep note, match rankings open August 8th, 2018, and the rank order list certification deadline is September 26th, 2018 at 9 p.m. Eastern Time. All right, so keep on top of those things. All right. Thank you for joining me for Anesthesia Circuit with John Kenny. Please join me next time as we continue to explore the world of anesthesia and continue to vigilantly pursue excellence. As always, if you have any suggestions, any questions, comments, anything that you think that you'd like to hear about in the future in one of our future episodes, please leave a comment below. I'll be sure to look at that and add that in there. Keep your eye out in the future for the consolidated keywords rapid review that I'm going to be putting together as well. That'll help residents, fellows, anyone taking exams to study while they're in the gym, in the car, something like that. A special thanks to the American Medical Association, to Open Anesthesia, to the Anesthesia and Analgesia Journal, and the American Society of Anesthesiologists. I'm John Kenny, and you've been listening to Anesthesia Circuit with John Kenny, the only show dedicated to all things anesthesia. Information disseminated in this show are for entertainment purposes only. Please consult your professional societies for the most up-to-date information on practice guidelines. Kenny's Anesthesia Circuit is a Vigilant Medicine Media production. Copyright Vigilant Medicine Media 2018.